Every 5 years, the American Heart Association updates its CPR and emergency cardiovascular care guidelines based on the most current science. The 2010 AHA guidelines for CPR and ECC are once again based on the largest review of resuscitation literature ever published. For many topics, the review of the PALS literature resulted in refinement of existing recommendations rather than new recommendations. Some of the major science changes for 2010 include immediate CPR, beginning with chest compressions for a victim who is unresponsive and not breathing or only gasping, CAB versus ABC. Continued emphasis on provision of high-quality CPR. Modification of recommendations regarding adequate depth of compressions. Recommendations regarding use of an AED for infants. Slight modification of the defibrillation energy dose. Revised recommendations for use of capnography or capnometry to confirm endotracheal tube placement. Recommendation for titration of oxygen after return of spontaneous circulation. Minor changes in medications used during cardiac arrest and shock. Expansion of recommendations for post-arrest care. New diagnostic consideration for sudden cardiac death. We will now look at each of these changes in more detail. Providers should give immediate CPR, beginning with chest compressions for any victim who is unresponsive and not breathing or only gasping and with no pulse palpated within 10 seconds. Treat the victim with gasps as though there is no breathing and begin CPR with chest compressions, not rescue breaths. The 2010 recommendations changed the mnemonic ABC to CAB. The new sequence should only delay rescue breaths by about 18 seconds, the time it takes to deliver 30 compressions. The new CAB sequence was adopted for 2 reasons. First, in adults, cardiac arrest is often sudden. At the time of sudden cardiac arrest, the blood oxygen level is usually normal, so compressions are initially more important than ventilations. Second, the new sequence starts with the CPR skill easiest for the rescuers to perform. It is hoped that this sequence will result in more frequent bystander CPR that will benefit all victims of arrest. The most important resuscitative measures are high-quality chest compressions and rapid defibrillation. It is critical to initiate chest compressions as soon as possible. Sudden cardiac arrest is much less common in pediatrics than in adults. Most pediatric arrests are asphyxial, so hypoxemia is likely to be present at the time of the arrest. It is critical to initiate ventilations along with compressions as soon as possible for pediatric victims. However, in an effort to avoid confusion by having different steps for victims of different ages, the compression-first approach was adopted for victims of all ages. It will only delay initiation of ventilation for a few seconds. The AHA believes that use of the same sequence for victims of all ages and beginning the sequence with compressions will increase the likelihood that bystander CPR will be provided. In 2005, we emphasized high-quality CPR. As a result, there is emerging evidence of improved outcomes, so in 2010, we continue to emphasize high-quality CPR. Basic life support is not just a set of skills used until you begin advanced life support, but rather the foundation of pediatric advanced life support.
28, 29, 30.
High-quality CPR is essential to increase a victim's chance of survival. During cardiac arrest, high-quality CPR, especially high-quality chest compressions, is critical to increase the coronary perfusion pressure and blood flow in order to achieve return of spontaneous circulation. This term may be abbreviated with the initials ROSC. One result of effective chest compressions is a higher coronary perfusion pressure, which is the difference between the aortic diastolic pressure and the pressure in the right atrium. The higher the coronary perfusion pressure during CPR, the better the victim's chance of survival. If the coronary perfusion pressure is too low, the victim won't survive. Here you see pressure measurements recorded during CPR. As you can see, during an uninterrupted series of compressions, the coronary perfusion pressure gradually increases. However, every time compressions are interrupted to give breaths, blood flow stops and coronary perfusion pressure falls dramatically and remains low as long as compressions are interrupted. When chest compressions are resumed, it takes several compressions to restore the coronary perfusion pressure to the level it was before the interruption. The more interruptions in chest compressions, the lower the coronary perfusion pressure and the lower the victim's chance of survival. Therefore, the critical elements of high-quality CPR include start compressions within 10 seconds of recognition of cardiac arrest. Compress at an adequate rate of at least 100 compressions per minute. Compress at an adequate depth of at least 2 inches or 5 centimeters for adults. For infants and children, compress at least 1/3 the depth of the chest. This will be about 2 inches or 5 centimeters for children and about 1.5 inches or 4 centimeters for infants. Allow complete chest recoil after each compression. Minimize interruptions. Try to limit interruptions in compressions to less than 10 seconds. Give effective breaths that make the chest rise. Avoid excessive ventilation. You reduce blood flow each time you interrupt chest compressions to give breaths, attach AED pads, or switch compressors. In order to minimize interruptions in chest compressions, yet still provide adequate ventilation during CPR, lone rescuers should use a 30-to-2 compression to ventilation ratio in infants, children, and adults. When 2 healthcare providers perform CPR, the compression to ventilation ratio is 15-to-2 for infants and children up to the age of puberty. At puberty, the compression to ventilation ratio changes to 30-to-2. High-quality chest compressions provide about 25 to 33% of normal cardiac output. Therefore, to match ventilation to perfusion, the total amount of ventilation provided per minute only has to be about 25 to 33% of normal. This should match the quantity of ventilation provided to the cardiac output from chest compressions. Any additional breaths are unnecessary and may actually be harmful. If you give too many breaths or breaths that are too large during CPR, you create positive pressure in the chest and reduce the filling of the heart with blood. This will limit the blood flow generated by the chest compressions. Based on new data, rescuers should compress at least 1/3 the anterior-posterior diameter of the chest. This corresponds to approximately 1.5 inches or about 4 centimeters in most infants and about 2 inches or 5 centimeters in most children. During cardiac arrest, when a shockable rhythm is present, survival requires defibrillation. In infants, manual defibrillators are preferred to an AED for defibrillation because manual defibrillators enable better adjustment of the shock dose. However, if a manual defibrillator is not available, an AED equipped with a pediatric dose attenuator is preferred. If neither is available, an AED without a pediatric dose attenuator may be used. The delivery of a high-dose shock is preferable to no shock when the infant has a shockable rhythm. It is acceptable to use an initial dose of 2 to 4 joules per kilogram for defibrillation, but for ease of teaching, an initial dose of 2 joules per kilogram may be used. For refractory VF, subsequent shocks should be at least 4 joules per kilogram or higher, not to exceed 10 joules per kilogram or the adult maximum dose. Limited evidence is available about effective or maximum energy doses for pediatric defibrillation, but some data suggest that higher doses may be safe and effective. Given the limited evidence, the new recommendation is a minor modification that allows higher doses up to the maximum dose most experts believe is safe. Exhaled carbon dioxide detection with capnography or a colorimetry device is recommended in addition to clinical assessment to confirm endotracheal tube position for neonates, infants, and children with a perfusing cardiac rhythm. This recommendation applies to all settings, including out-of-hospital, emergency department, intensive care unit, and operating room. Exhaled CO2 monitoring generally confirms placement of the endotracheal tube in the airway. Monitoring of exhaled CO2 may allow more rapid detection of endotracheal tube misplacement or displacement than monitoring of oxygen saturation. Because patient transport increases the risk of tube displacement, continuous exhaled CO2 monitoring is especially important during intra-hospital or inter-hospital transport. If available, continuous monitoring of exhaled CO2 using capnography or capnometry may be beneficial during CPR to help guide therapy, especially the effectiveness of chest compressions. Continuous waveform capnography displays the partial pressure of exhaled carbon dioxide and enables determination of the partial pressure of carbon dioxide at the end of exhalation, called the end tidal CO2. During CPR, end tidal CO2 values consistently less than 10 to 15 millimeters of mercury suggest that efforts should focus on improving the quality of CPR, such as improving chest compressions and making sure that ventilation is not excessive. In addition, return of spontaneous circulation typically causes an abrupt and sustained rise in the end tidal CO2. So the use of continuous waveform capnography may reduce the need to interrupt chest compressions for a pulse check. Once the circulation is restored, it is important to monitor the child's arterial oxygen saturation and titrate oxygen administration accordingly. The goal is to avoid hyperoxia, a high arterial oxygen tension, while ensuring adequate oxygen delivery. Recent data from an adult study demonstrated worse outcomes with hyperoxia after resuscitation from cardiac arrest. Data suggests that hyperoxia enhances the oxidative injury observed after ischemia and reperfusion, such as occurs after resuscitation from cardiac arrest. An arterial oxygen saturation of 100% may correspond to an arterial oxygen tension anywhere between approximately 80 and 500 millimeters of mercury. As a result, to reduce the risk of oxidative injury, it is generally appropriate to decrease the inspired oxygen when the oxygen saturation is 100%. It may be reasonable, when the appropriate equipment is available, to titrate oxygen administration to maintain the arterial oxygen saturation between 94 and 99%. There are some new recommendations regarding the administration of calcium and etomidate. There is recent evidence that routine calcium administration in cardiac arrest provides no benefit and may be harmful. Therefore, routine calcium administration is not recommended for pediatric cardiopulmonary arrest in the absence of documented hypocalcemia, calcium channel blocker overdose, hypermagnesemia, or hyperkalemia. Routine calcium administration in cardiac arrest provides no benefit and may be harmful. Use of etomidate has been shown to facilitate endotracheal intubation in infants and children with minimal hemodynamic effect, but is not recommended for routine use in pediatric patients with evidence of septic shock. Evidence of potential harm from the use of etomidate in both adults and children with septic shock led to the recommendation to avoid its routine use in this setting. Although there have been no published results of prospective randomized pediatric trials of therapeutic hypothermia, based on adult evidence, therapeutic hypothermia cooling to a temperature of 32 to 34 degrees centigrade may be beneficial for adolescents who remain comatose after resuscitation from sudden witnessed out-of-hospital VF cardiac arrest. Therapeutic hypothermia has also been shown to be beneficial for the treatment of newborns with hypoxic ischemic insult. Therapeutic hypothermia may also be considered for infants and children who remain comatose after resuscitation from cardiac arrest. Further pediatric data are needed. There is increasing evidence that some cases of sudden death in infants, children, and young adults may be associated with genetic mutations. These genetic mutations cause cardiac ion transport defects known as channelopathies. Channelopathies can cause fatal arrhythmias, and their correct diagnosis may be critically important for living relatives. When a sudden unexplained cardiac death occurs in a child or young adult, obtain a complete medical and family history. This includes a history of syncopal episodes, seizures, unexplained accidents or drowning, or sudden unexpected death at under 50 years of age. All previous ECGs should be reviewed. Where resources allow, children who die from unexplained cardiac death should have an unrestricted, complete autopsy. This should be performed by a pathologist with training and experience in cardiovascular pathology, if possible. Tissue should be preserved for genetic analysis to determine the presence of channelopathy. If a channelopathy is discovered during autopsy, surviving relatives should be evaluated by a medical professional to determine whether they too have channelopathies. This concludes the overview of the major pediatric changes in the 2010 AHA guidelines for CPR and ECC.